Next month we are live. We can start. Thank you.
Yeah, thank you.
Okay.
Yesterday, we learned that a stroke, brain tumor, trauma, or disease that affects the brain tissue can also damage the parts of the brain that control language and speech, which cause a language disorder known as aphasia. Aphasia may result in difficulties like thinking of words, forming words and formulating sentences, difficulty in understanding speech, difficulty in reading, writing, and spelling, so on and so forth. Aphasia is not a loss of intellect, but rather a loss of impairment of language. Persons with aphasia can regain their language loss with treatment, but the key word is early language intervention by a qualified neurorehabilitationist. It means that the habilitation should start the moment we detect aphasia so that the devastating effects could be minimized and the patient can be restreamed to society. Good evening. I'm Meenakshi Vadera, an audiologist and speech language pathologist. And on behalf of Indian Speech and Hearing Association, I welcome you to yet another very interesting session of Speech and Hearing Awareness Annuals 2020. The primary purpose of this event is to reach out to the general public with the objective to make them learn all, all about the necessary things about various disorders related to speech, language, swallowing, hearing, balance, and also educate them about their various treatments. But before we start today's session, I would like to invite Dr. Sunil Kumar Ravi, our Joint Secretary of Indian Speech and Hearing Association, to give us to say a few words.
Thank you, Meenakshi ma'am. I, on behalf of the Indian Speech Language and Hearing Association and the Executive Council of the ISHA, heartily welcome each one of you to this panel discussion on dementia and cognitive communication rehabilitation. I'm very sure that this particular session is going to be very informative under the moderatorship of Ms. Annamajaj and Ms. Sonal Chitnis, and we have got very well experienced panelists today, ranging from speech language pathologist to neurologist to neuropsychiatrist and also neuropsychologist, who is going to give us an information to all the public about what to look for whenever a person is having a kind of a memory impairments or any other cognitive impairments. And I'm very sure that this is going to be a fruitful session. And I welcome Dr. Nehal Kotari, Dr. Sujit Jagtap, Dr. Ennapadam Krishnamurthy, Dr. Rajendra Damija, Dr. Ms. Bala Tripur Sundari, Ms. Dwala Narayanan, and Mr. Ruben Thomas Varghese for this particular wonderful session on cognition and communication and importance of these things in our day-to-day life. Thank you, and I request the moderators to begin with the session.
Thank you, sir. So, as Sunil sir has already said that today we would be talking about dementia and its aspects. So when we hear the word dementia, we correlate it with aging and changes or damage to brain cells due to aging. Dementia is a general term for loss of memory, language, problem solving, and other thinking abilities that are severe enough to interfere with daily life. What are the factors contributing to dementia? Can it be reversed or slowed down? Let's hear what our interdisciplinary expert panel has to say about it. But before we start, yes. So, sorry, yeah. Today we had, quite a full day. We had a quiz for the students, and now we have this session, which is on dementia and cognitive communication rehabilitation. And following this, we have another session on role of media. So please stay tuned to that. And tomorrow, yet another very interesting session on singing. It's voice care, and a lot of aspects will be covered during that. So please tune in tomorrow as well. Today's session is being moderated by a very talented and experienced speech language pathologist and audiologist, Miss Annama George. She was formerly working as an SLP at SCT IMST Trivandrum, and now she's currently into private practice. She has 24 years of experience. She's a gold medalist postgraduate from Mysore, and she has won many awards, best poster awards at Epilepsy Congress, at the joint annual conference of Indian Epilepsy Association and Indian Epilepsy Society. She's also she recently in our last IshaCon in 2020, she got the Professor R.K. Oza Oration Award, and she has written many publications and she's been invited to many talks, and her clinical interest area of interest is aphasia, rehabilitation, multilingualism, dementia, epilepsy. Welcome, Miss Anama. And our second moderator is Miss Sonal Vichitness. She's a very young and dynamic neuro SLP. She's a coordinator of Isha SIG Clinical Audiology Aphasiology Group, and she's assistant professor at Bharati Vidyapeeth University Medical Colleges School of Audiology and Language Pathology, Pune. She's a consultant speech language pathologist at Neurology Department, Dheeranath Mangeshkar Super Specialty Hospital. She is also a member of Isha, IAN, IFNR, WFNR, and NSI. And she's also had achieved a lot of awards, received a lot of awards at various organizations, especially at like World Stroke Congress, which was held at Hyderabad, and Sant Kavi Surdas Award at the second annual convention for challenge students. Her area of interest are physiology, cognitive neuroscience, neuro rehabilitation, stroke, epilepsy, dementia, MCI, education and humanities in medical and allied health education, and patient advocacy. Over to you, Ms. Sonal Chitnis.
Thank you so much, ma'am, for the great kind words and the introduction. It's always heartening to represent our own parent body, supporting you for your all the noble advocacy efforts, particularly in neuro rehabilitation, the brain health of speech, language, cognition, communication. What I always try my best to help from the parent body, and the support from the Indian Academy of Neurology, Neuro Rehabilitation, IFNR and WFNR. We are here to have a very enlightening and a very nice panel discussion on a public awareness on a dementia, cognitive communication rehabilitation. I welcome you all. We have a very great expert multidisciplinary team who would be enlightening us today on the dementia. So I welcome all of you. Please stay tuned and have active participation in terms of dementia and the aging and cognitive impairment. You would like to get more and more information from the expert committee who would be enlightening you today. So with that, I start my presentation, and we will start with a team introduction. Are my slides visible?
Yes, Sonal, they are visible.
So let's know our expert committee of panel discussion today in the dementia who would be representing and enlightening us. We have Professor Rajinder Dhamija, who does not need introduction in the neurology world. He is a well-known figure in international neurology academia. He's a movement disorder specialist. He's a professor and head of neurology at Lady Hardinge Medical College in New Delhi. He's a current chair of movement disorder rehabilitation at WFNR. The senior fellow has been MCI and at national bodies serving as a main expert. Welcome, Professor Dhamija, sir. We look forward to listen to you. We have another expert in neuropsychiatry and cognitive behavioral disorders, Dr. Ennapadam Krishnamurthy, sir. He is the president of INA, and he's very balanced in academia and the clinical world of neuropsychiatry, cognitive neurological aspects. He has got many awards to his credit. He has written many books and chapters about cognition, dementia, epilepsy. His book Global Approach and series of book Cambridge Press is very, very helpful. We should all get back to the we should read his books, which are very enlightening for the neuro rehab professionals in cognitive neurology and neurosciences. Welcome, sir. We have another neurologist, epileptologist, Dr. Sujit Jagtap, young dynamic neurologist who heads director of Epilepsy Center, Bajaj Epilepsy Center at Pune, and he's a fellow of Cleveland Clinic. He has been having a very good experience at Suchitra with the Cognitive Neurology Center, and he's come back to Bharati Vidyapit Pune and Hirnath Mangeshkar. He is very balanced with his work in dementia and of epilepsy and cognitive neuro disorders. We look forward to listen to you, sir. We have another dynamic and international and level known neuropsychologist having a very great interest in bilingualism, cogneurology and rehabilitation, Ms. Jwala Narayanan, and she would enlighten us about dementia and rehabilitation today. Welcome, ma'am. And we have our own speech pathologist, Dr. Nehal Kothari. She is a board certified American Speech and Hearing Association Triple C, and she's director at Let's Talk Speech Therapy at Mumbai. Where Nehal has a very great experience about Parkinson's movement disorder and neurocognition disorders. Welcome, Nehal. We would like to listen to you and learn from it. We have another expert, Bala Tripura Sundari. She is known for her advocacy efforts in Alzheimer's and Related Disorder Society of India and Hyderabad chapter. She is very dynamic in terms of helping the caregivers of dementia and the person with dementia, their laws, their activities. She's been a founder of ARDSI Hyderabad chapter and a trustee. Welcome, ma'am. We look forward listening to listening to you regarding advocacy in dementia. And our last panelist is Mr. Ruben Verghese. He's a scientist at AISH and has been working in speech and language and cognitive rehabilitation of dementia and agnostics. Welcome, Ruben. So with that, I start the introduction to dementia. We all know dementia is highly prevalent in elderly, advanced aging, and it has got very important biodiverse cultural implications with respect to the literacy, aging, cultural aspects, so that we need to understand how do we assess, how do we intervene dementias and related neurocognitive disorders. There are various causes to dementia, and few are Alzheimer's, vascular, and Parkinson movement disorder. So dementia importantly is cognitive abnormal aging. It involves loss of language, memory, communicative skills, praxis, emotional, personality, and cognitive impairment. Importantly in abstraction, judgment, executive functions, and so forth. So common cardinal signs of dementia are poor memory, poor judgment, memory and the cognitive impairment affecting daily living, problems with abstract thinking, WH questions, forgetting people, words, loss of initiative, misplacing things, difficulty in performing the daily living activities and the independence how one was earlier doing, change in personality, disorientation, mood and behavior changes. These are the some dementia signs and symptoms. So what happens when someone suffers with cognitive impairment? So deterioration in cognition can lead to social cognitive impairment, visuospatial impairment, and verbal and cognitive communicative impairment. So we need to have a teamwork while assessing and intervening person with dementia. Speech language pathologists play a dynamic role in identification, assessment, counseling, collaboration, in prevention of dementia, where we have a modifiable factors in terms of safe swallowing, cognition, language and communication, and importantly, advocacy. With this, let's move to listen to our great dynamic panelist. I hand over the stage to Annama ma'am.
Okay, before I start with my introduction, I just want to uh, ask the Anil to please upgrade Rajendra sir as panelist, please.
It's done, ma'am. You can. It's
Okay, thank you so much. So I take this opportunity to once again say good evening to all of you and welcome you all to this panel discussion. Dementia, as we know, not only affects the individual per se, it affects the caregiver and the society at large. I say this with a very heavy heart when on every September 21st, all of us are so happy to celebrate World Alzheimer's Day, and there are a lot of events lined up for it, and there's a huge lot of media frenzy at that time. And that's, I think, the only day that we remember those who can't remember. After that day, we forget again, and we wait for the next September 21st to come again. A lot of things that run through um, the mind of the speech pathologist, especially the younger ones, is what is our role here? Do we have a role to play when there is dementia? What is our role? How can we help individuals with dementia? So I'm now going to welcome this. You already heard the introduction on the panel. We're going to move on to a set of questions. I have a small request to all my panelists that please be brief because we got a whole lot of questions to run through. And if time permits, we will be taking questions from the audience too. So can you please put up the first slide, Sonal? Can we have the first question, please, Sonal? Yeah. The first one is, how frequently is dementia seen in the Indian population? I'd like to ask Dr. Krishnamurthy to answer.
First, thank you to the organizers and my young friend Sonal for inviting me to be here. It's a great pleasure, and I'm very happy that the speech and language group are focusing on a condition like dementia, which is very important. It's a disorder of the elderly, and therefore you really start counting numbers after 65 years of age and more. And in that group, the general figures are 5 per thousand. Having said that, it's very, 5%. And as people get older, you're talking about 20% over the age of 80. And if you hit a century, you will hit 50%. And that, of course, is well seen in countries like Japan and the US. Now, India is not far behind because we have a growing population of the elderly. Many more people are living to be much older in India. And we estimate, according to the Dementia India report, that there are almost 4.5 million elderly with dementia living in India. This is an update of the report from 2020. So the numbers are very, very large. We must also keep in mind that we have the distinction of being the diabetes capital of the world. And diabetes is a very important risk factor for dementia. So sub 65, there are probably a lot of people with diabetes with what we call mild cognitive impairment, which is a pre-dementing stage where we'll talk more about that later. But I think it's important for us to remember that that also constitutes a evolving public health problem. I hope I've answered the question.
Thank you, sir. Next one. Sonal, next question, please. Yeah, the next question I'm addressing to Dr. Rajendra Damija. Sir, what are the different types of dementia?
At the outset, I thank Dr. Sonal and all the members of this organizing committee for inviting me to speak on this, on a topic which is very close to my heart, dementia.
Thank you, sir.
I basically do geriatric neurology, and one of the major problems of geriatric neurology is dementia. And as you know, our population is aging population. At the moment, we have 65% of the people less than 35 years. Am I audible?
Yes, sir.
So at the moment, we are young population, young country, but in next 20 years, probably in 2040 or 2050, we will be having many more people
So we can't hear you.
in that group. Hello, can you hear me now?
Yeah, now we can.
So what I was trying to say, with the increasing longevity of our population, we are going to have a great number of people who will be elderly and will have degenerative diseases like dementia in future. So that's going to be a major public health problem in years to come, and we should be cognizant of this problem and be careful about this. So coming back to your question about the types of dementia. So most common is of course the Alzheimer's one, named after Alzheimer's, who coined this term, followed by Charcot. So this is one of the commonest form of dementing illness, uh, comprising about 65% of the whole dementing population. That is very peculiar in terms of loss of short-term memory or new learning problems, with the hallmark pathology being plaques and tangles in the brain. So this is very typical and has a clinical phenotype, very specific, and a very specific pathology. So the diagnostic markers are evolving, biomarkers these days, and at the moment the diagnosis is usually by neuropsychology or by the clinical. The second most common is vascular dementia in our country and world over, which is because of the recurrent strokes. And this is a step-ladder type of a neurological deficit, which goes on accumulating the disability and results in dementing illness. And third, of course, is the dementia uh, known as frontotemporal dementia, which is probably more relevant to the group today because it involves the language predominantly along with the frontal behavior. So there is either semantic aphasia or primary progressive aphasia. So that's one of third common and a major cause of dementing illness in this population group, elderly. And fourth one is, of course, dementia with Lewy bodies or dementia with Parkinsonism or Parkinson disease with dementia, where I do come into picture and we see a lot of patients of Parkinson disease who develop dementia. Most of the movement disorder neurologists all over the world think that dementia in both conditions, Lewy body dementia as well as Parkinson disease with dementia, are the same disease having a different timeline. So cutoff is 12 months. If the Parkinson patient develops dementia within 12 months of onset of Parkinson disease, it is the Lewy body dementia. Otherwise, it is Parkinson disease with dementia. So Parkinson disease with dementia is predominantly with the Parkinsonism, along with the uh, dementic illness or the memory problems. The Lewy body dementia is a very specific term because this involves fluctuation with the cognitive decline and psychiatric behavior. And one thing is very important to consider, that because we want to, if we give antipsychotics to these patients, it worsens actually. So one has to be very careful in diagnosis, whether it is Lewy body dementia or it is the Parkinson disease with dementia, or it is frontotemporal, or it is vascular, or it is Alzheimer's disease. One last thing which I want to convey to all the viewers and the attendees is that dementia is not only the memory problem. Memory is one domain, but there are more domains which complex makes a dementing illness or a diagnosis of dementia. There are behavioral problems. There are visuospatial problems like people forgetting their ways or forgetting rooms and drawing rooms and losing their ways. Similarly, there is a language problem and the behavioral problem. So all these domains, when they are affected, plus memory plus one of these domains, then we call it a dementia. It's just not the loss of memory. I hope that answers your question.
Yes, sir. Thank you. Next question. Sonal, can you project the next question? Dr. Sujit, I'd like to ask you, what are the reversible causes of dementia? And are there any modifiable risk factors of dementia?
At the outset, I would like to thank Isha and Sonal for giving me this opportunity. And the dementia is a very important topic. And as previously both speakers has told you about the incidence of dementia and what are the causes of dementia. And what we know, once there is a dementia or is irreversible, but there are reversible causes of dementia. And most important thing, how to remember what are the reversible causes. It is like what we can say, we can remember by the mnemonic dementia again. So D stands for drugs. So some of the drugs, anticholinergic and sometimes antipsychotics also can cause slowing. And again, there will be the memory impairment. Then emotions, especially whenever somebody is in significant depression, it can present as a pseudo dementia, what we call it as a pseudo dementia. So emotions are also important part. Then there are the metabolic conditions like hypothyroidism. Then already Dr. Krishnamurthy also said there is a risk factor is sometimes in diabetes also. So metabolic factors also can lead to the memory impairment. Then comes the environmental factors, like there may be the metal poisonings, heavy metal poisoning, which can lead to dementia. Another important is nutritional. So somebody who is having predominantly vegetarian diet, they can present with dementia. So vitamin B12 deficiency. Then there is alcoholics who present with the dementia because they have thiamine deficiency. Then we have a niacin deficiency, which can present with diarrhea, dementia, and dermatitis. Then there will be the eyes like infections, what we have, HIV we have, syphilis we have, which also can present with the infection. And T for toxins. Also there are some toxins which can cause dementia. Least but not uncommon is again what we see after the 60-65 years, suddenly there is a change in behavior and there is a worsening of not worsening of sensorium, but some deep seizures and other things, and patient becomes forgetful. That is like autoimmune encephalitis, especially VGKC, what we call as LGI1 encephalitis or Casper2 encephalitis. These people also present with the dementia, and this is one of the treatable cause. Then there are some vascular causes, especially when there are dural arteriovenous fistulas. They can present with the rapidly progressive dementia, which if we pick up early, they are reversible. And again, sometimes tumors also can present with the dementia. Coming to modifiable risk factors for dementia, the important points against is if you have hypertension, if you have diabetes, you should have good control of your diabetes, you should have good control of your hypertension, because they can present with the vascular dementia and we can prevent that. Then you should be active throughout, you should not just sit idle, you should be interested in all activities of day-to-day life, reading newspaper, then listening to the news, trying to solve puzzles and other things. You should avoid, you should have a non-vegetarian diet, or if you are vegetarian completely, then you have to take vitamin B12 supplements. Then you have to check your thyroid regularly. So because hypothyroidism is one of the major risk factor for dementia.
Thank you, Dr. Sujit. Next question. Dr. Krishnamurthy, sir, can you please tell us how we differentiate between normal aging, MCI, and dementia?
So I think that's one of the most difficult questions that professionals face and families face also. People do slow down with age quite normally, and therefore benign senescence is an old term that was used to talk about old age forgetfulness, a little absent-mindedness, a little bit of cognitive slowing, a little bit of time lapse before actually addressing a problem or asking a question. Slowed reflexes, not just physically, but also cognitively. Mild cognitive impairment is a more specific term which really talks about a problem with memory and possibly other cognitive functions, which is of clinical significance but does not affect activities of daily living. There is some, what shall I say, disagreement about whether simple and complex activities of daily living should be discriminated in this category. But in effect, the person appears to be reasonably normal, and the common activities of daily living they are able to do. But when tested, and when you ask the family, they are forgetful. When tested, they do score on the border zone of most commonly used cognitive tests. Give you an example, the Adam-Brooks cognitive examination, which was validated from Chitra, a score of between, say, 85 and 90 out of 100 would make you wonder whether they have MCI, or even between 80 and 85 would make you wonder if they have MCI. And then, of course, dementia is much more frank in the sense that they do have memory loss. They do have other cognitive difficulties. And as has been pointed out by other speakers, it need not always be memory loss. It can be multi-domain cognitive impairment with memory being spared, as in vascular dementia. But also, this starts to affect their activities of daily life, and this starts to affect their quality of life. So their role functioning as an individual starts to be impaired, and their need for assistance from family starts to grow, and not just for physical reasons. And I think that that is something that we need to think about when we say that a person has dementia. So the borderlines between these can be quite thin, and we can be sometimes wrong in estimating MCI as dementia or dementia as MCI. But I think it's important to be aware that these three benign senescence, MCI, and dementia continue to be important clinical categories for most of us.
Thank you, sir. Next question, Sonal. Dr. Rajender, could you please answer the question, how commonly are cognitive impairments seen along with movement disorders?
Thank you for this question, and this is very, very relevant because we see Parkinson disease as a prototype of movement disorders. Parkinson disease has a natural history of going into different phases from prodromal to early to mid to advanced disease. And most of the patients with Parkinson disease will develop some kind of cognitive decline in 10 years' time, say after 10 years or near about that. So that's the natural history of disease. And majority of these patients, when they live up to 25 years after the diagnosis of the patients, will have major dementic illness along with psychosis and other features. So it is very common to have dementia in Parkinson disease after a 10 to 15 to 20 years of time. But more importantly, prototype of movement disorder with dementia, which presents as a dementia, as I told you, is dementia with Lewy body. That's one. And that is quite challenging to treat because sometimes the people are put on antipsychotic because of their behavioral problems, and that can worsen the psychotic or the dementic illness. The third important cause of dementia in movement disorder is the Huntington's disease (HD), which can be, which is dominant disease, runs in the family with the CAG repeats with the anticipation. That means young people in subsequent generations will have an early onset disease, and that's a coriform disease with the chorea and the dementia as a presenting or initial symptoms. So that is very typical. If you have a patient, young patient, a male or predominantly with dementing illness, with movement disorders in the form of chorea, and a strong, very strong family history, you always think of Huntington's disease as a cause of dementia. So there are other forms of dementing illness which present with movement disorders, but these are the three most common clinical entities in which there is a dementing feature as a predominant one. And all of them are challenging because the treatment with this advanced disease of dementia, along with the movement disorders, sometimes can be difficult to treat.
Thank you, sir. Sonal, next question, please. Jwala, I have a question for you. How is cognition routinely assessed during routine clinical practice, and what are the tests that are commonly used in dementia evaluation?
Firstly, thank you, Isha and Sonal, for inviting me. Anuma, as you said, I think it's a very important area. We all should be doing a lot more public awareness than just 21st September. So thank you for having me. So in terms of cognition, we are basically testing thinking processes. So everything right from memory, attention, problem solving, working memory, those are things that we test with standardized tools. And these tools are basically paper pencil tests, and sometimes they're computerized tests. So what we do is we see how a person does on a particular test, and then we compare them with healthy controls, people of of the same age in education and then compare and see if their scores drop below an average or much below an average, to then see if there's something going on there. And the reason why we do so many tests is because we try to get a profile of scores, because these profiles tell us what type of dementia a person may have, or if it is mild cognitive impairment, or if this is definitely dementia. So we do a lot of cognitive tests, we do memory tests, we do language tests, we do also behavioral tests to see if there is any behavioral symptoms that we can pick up, and also emotional. So we do look into depression, because all this would give us a clue into what type of dementia it might be. And some of the commonly used tools, of course, we use the Addenbrooke, which is a good cognitive screen. I know some parts of India use the MOCA. We also use the HMSC. And then in terms of more standardized neuropsychological tools, we usually have a lot of word lists for memory tests. Sometimes you give a non-verbal picture drawing to see if they're able to see a picture and then draw it again. And then we also do a few tests where they have to, it's more like little puzzles to see if they're able to solve problems. So these are some of the tests that we do as of now.
Thank you, Jwala.
And I think one of the main challenges right now is we don't have enough Indian norms for a lot of the neuropsychological tools. So, I mean, there are different people working to sort of derive more norms at the moment, but we all need to work a lot more together right now to firstly have standardized tools between us as a country, and then try to generate more norms for that.
Thank you for bringing that up, Ujwala. Next question, Sonal. Okay. What are the challenges faced while diagnosing dementias? I would first ask Dr. Krishnamurthy to answer that.
So the first thing we have to ask ourselves is, whether it is dementia in the first place. As Dr. Jagpat has pointed out, there are a number of reversible reasons why a person may present with dementia. Then, of course, it's very important to exclude mental health reasons as to why a person may have dementia. Depression is not an uncommon problem in the elderly, and I think we are reading and learning more and more about depression in the elderly. And that can manifest as dementia, as can delirium, as can a range of other problems. So it's very important to unravel that and make sure that there isn't a metabolic or a mental health reason why the person is presenting with the dementia. Then, of course, we come to subtyping. And the most common issues we run into in Asia are differentiating between Alzheimer's disease and other forms of dementia. And of course, vascular dementia is extremely important. And the combination of Alzheimer's and vascular, the comorbidity, is also seen in some people. Dr. Rami just talked about movement disorders and dementias, and of course, frontotemporal dementia. So the subtyping can be a great challenge when it comes to diagnosing dementia. It's a clinical diagnosis, so you really should not need any, diagnostic tools to make the diagnosis. All the diagnostic tools that we use are to exclude other things. And I think that that's the way we really need to be looking at it. And there are wonderful clinical signs that people describe that one needs to learn if one is a practicing professional. To give you a very simple example, at Queen Square, where I trained, they used to teach us about the sloppy tie sign, which is that the person with Parkinson's disease and cognitive impairment would often be the one with a stain on his tie because they tend to drop things on themselves. And similarly, the person with Alzheimer's disease is the one who walks into the room terribly confidently, but has, when you start talking to them, you realize they are not remembering things at all. So there are ways in which one can make a diagnosis. And it is essentially a very clinical diagnosis, is what I'd like to reiterate. And that also one must exclude a number of conditions that are treatable in making the diagnosis.
Thank you, sir. Jwala, do you want to add something to that? Any challenges
Yeah,
faced from the neuropsychological perspective?
yeah, I think I would agree with Dr. Yeski as well. It is a clinical diagnosis, and especially in India, like I just mentioned, that we do not have so many standardized tools, and we don't have normal sort of norms for a lot of these tests. So I think an experienced clinician is very important, because sometimes a lot of patients can do really poorly on scores, but it might not be dementia, and it might be the other way around as well, where they do really well, but we can miss the dementia. So really being able to pick on things that they're doing from the history. I feel the history gives us so much, and it's extremely important, especially in the Indian context, to spend a lot of time with the history. Like I can go up to an hour just to take good history, to really go into where they were before and what changes, I think we're not great historians either. So when we give a clinical history, we're not very good at giving history. So we really have to. Sometimes I feel like a detective trying to sort of, find out what's really going on. So I do feel it's very important that we have good clinical skills and be able to draw on different skills as well. So we do need to know a lot of neurology and a lot of speech and language, because sometimes we don't have access to all these different specialties either. So it's a lot of interdisciplinary work that makes a diagnosis of dementia, and sometimes if you don't have access to it, then you do need to know it yourself.
Thank you, Jwala. Dr. Rajinder, sir, you would like to add any challenges?
Yeah, absolutely. I think what I agree what the other two speakers have told. This actually is sometimes you feel there is a denial or loss of insight in the patients. So it is a role of the caregiver and the other family members to pick up these signs, early signs, whether the patient is repeating the same thing again and again, whether having medicines or breakfast or anything like that. So history is very important to pick up early signs in a diagnosis. What I need to emphasize at this point is I believe that many of the caregivers are also present in this webinar. So it is not a disease affecting one individual. It affects the whole family. So the important message to the caregivers and the family is not to react the way the patient is behaving. So the patient is a patient. That is why he has no insight, and that is why he doesn't know what he is doing or what he is speaking. So role of the caregiver is very important. The family has to understand that they are dealing with a patient, not a normal individual. So if the patient is aggressive, obviously the family does not have, or caregiver does not have to react or to retaliate or to you know uh, uh, in a similar way. They have to understand, and the patient's management is equally difficult as the diagnosis is. So that's one thing that the one has to understand and make the caregivers understand the reality of dementia, because it's a long drawn process. It's a involving all the family members. In a country like ours, where we don't have a dedicated aged care centers or memory clinics or dementia the centers. So obviously, the role of family physician also is very important to manage day-to-day problems or issues which come up with the medications and the other things. The third last point which I want to emphasize is that most of these patients deteriorate because of two reasons. One is the sepsis somewhere, either in the lungs or in the urine, for example, and the second thing is the drug interactions. So most of these patients would be on multiple drugs or polypharmacy, and it is very important that these elderly individuals have low tolerability or their decompensated renal functions and the liver functions. So they have to be given in a smaller doses as compared to the normal healthy individuals. And there are drug interactions, many a times one drug leading to the interacting with the other drugs. So any time when these patients deteriorate in terms of their acute decompensation, so one has to look for sepsis or the drug interactions, and always look at the list of medication the patient is taking and then find out which one can be taken off.
Thank you, sir. Next question, Sonal. Dr. Krishnamurthy, I'd like to ask you, do you have access to speech and language pathology services?
Yes, we do. In fact, for quite some time, we had someone excellently trained by Sonal on our team. And of course, unfortunately, after COVID, she had to return to Kerala. But we now have another person supporting us for speech and language. The challenge, of course, for clinics like ours is that we do a lot of distributed work. Many of our patients are at home. Many of our patients are admitted in care homes. And not all of them are mobile enough to come to clinic. And I think that this is the story of, if you look after older people with neurological and mental health needs or disabled populations, this is something you're going to encounter, which then means that whoever the person is, including the speech and language pathologist, they need to be willing to be mobile. They need to be willing to travel between clinics and sometimes even to home. And this is something that I do struggle with, because then you either need multiple people or, so that's a service provision problem. But we do have a speech and language pathologist, and we find them a very important part of our work. There's one point I want to make in addition, which I think will excite your group. We've now started using transcutaneous direct current stimulation together with speech therapy in our clinical work, and we have excellent results. And we're just writing up our first publication actually. Very, very good results with using TDCS and speech therapy together. And this is something that we are very excited by. And I think it's a huge opportunity for the speech and language fraternity to think about neuromodulation along with the work that you do. We use it in children, we use it in intellectually disabled adults, and we are using it in elders with mild cognitive impairment as well.
Thank you, Dr. Krishnamurthy. Dr. Dameja?
Yes, we do have access to speech pathology, but that's limited because we share SLP with the ENT department, and the ENT department has a lot of work to do with the audiology. So most of the time, the speech pathologist is busy doing audiometries, but they do come and help us out in our stroke clinic and stroke unit. So we have a dedicated stroke unit where we have team of dietitian, psychologist, physiotherapist, occupational therapist, speech pathologist, so and so forth. So, but we don't have a full-time speech pathologist at the moment. We used to have one, and she was doing excellent work, and we did a lot of assessment of swallowing in our Parkinson's patient. And in fact, we presented our work at the American Academy of Neurology at Philadelphia. With the help of our speech pathologists, we did a small study using dynamic MRI with real-time swallowing assessment in our early PD patients, and that was a landmark study. So obviously, there's a huge role of speech pathologists in either in the stroke or in Parkinson's disease or in other neurodegenerative conditions. And at the moment, we are struggling with having a full-time, but definitely having a speech pathologist is an asset to any team which deals with the degenerative disease like dementia, Parkinson, and stroke.
Thank you, sir. Jwala, I would like your take on that. Do you have SLP being part of your team?
Yeah, so I actually work at 3 hospitals. One of them, I don't have one. I have more than 3 speech therapists who are part of our rehab team. But I do also connect with a whole network of speech therapists across the city, because I find that helps a lot. Because I have patients coming from different parts of the city, and I feel speech therapy is something that needs to happen regularly. So if you want people to do it regularly, you need to connect them with people in their area or people who would come home. So I am always looking for speech therapists. So if you are someone in Bangalore, please do get in touch with me, because you make my work easier and I can just focus on what I'm good at, and I don't have to do any speech and language work. So yes, definitely. I think, and this is also to all, the public watching. It's extremely important to connect with speech therapists when you're referred to them by doctors, because that is something that will really help the patients, especially if they do have dementia, you want their quality of life to be good. This is something that's going to keep them connected for as long as possible. So please do reach out to them.
Thank you so much. And thank you to know that there are so many openings available. Anyhow, so Sonal, we'll move on to the next question. Okay, what are the behavioral issues seen in persons with dementia, Dr. Krishnamurthy, and how are these problems managed? I know that we touched upon some of it, but then
yes, I think behavioral and psychological symptoms are the most problematic part of dementia for families in particular. For one thing, it's the first reason why people present to clinic, not having been diagnosed until then. Second, behavioral and psychological symptoms make it extremely difficult for families to manage the patient, because you're thinking of someone who's an elder, someone who is respected by the family. And if they start manifesting some odd behaviors, it becomes extremely difficult for the family to even know how to react to those behaviors and how to respond to that individual. The kind of behaviors, of course, we talked about depression a little while earlier. So apathy, which is a much more serious problem in the sense that the person just sits for long periods of time. And even if they had a television channel on and a remote in their hand, they would not even bother to change the remote. So, change the channel and see if something else can be watched. So apathy is a huge problem, which we see. We also see abulia, which is I want to do things, but I lack the will to get up and go. So depression, apathy, and abulia is one set. The other problems are much more visible and much more problematic for families: irritability, anger, aggression, and even violence. This can be a huge problem for families. And of course, one does not understand what triggered the individual to behave in that way. And that makes it very, very difficult too. The third group of problems in what you see in frontotemporal dementia are various forms of disinhibition. So a person saying things that they should not say. Of course, many older people can become indiscreet as they get older. They just speak their mind. But this is quite different. It's not speaking their mind. It's saying things that are offensive, or saying things that are sexual or unacceptable, or behaving in a way that is sexual or unacceptable, approaching a family member in a way that one should not, disrobing in front of other people. All these can be huge behavioral and psychological symptoms that you see in people with dementia. You also see anxiety. It's sometimes very, very prominent in a person with dementia, especially in the early stage, and wandering, an incessant tendency to wander. And this is what gets them to leave their house and gets lost. The number of patients I have where the families are going around searching for them because they left the house in the morning to have cha and they just lost their way. It's not funny. And I think, therefore, that it's a very, very important domain of dementia management. My heart goes out to the families when they have to deal with it, because it comes with so many problems.
Jwala, would you like to add anything?
Yeah, so there are, of course, a range of behavioral issues, as Dr. Krishnamurthy just pointed out. So in terms of management, we started a center called CogWorks a few years ago. And quite frankly, I didn't know where we were going with that. But it's amazing what a turn it's taken and what we've learned through it. And it's basically an enrichment program that we call, where people come in a few days a week and we engage them in yoga, and then some creative activity. Some of them do art, some of them do tailoring, some of them do. So we look at what each one's capacity is, and then they do activities based on their capacity. And a lot of it is creative activities. And we also have someone I really like to talk about is one of my patients who's had dementia now. One of my first patients I saw actually, and now she's had dementia for about 15 years, and she teaches tailoring to some of our students and some of the other patients with dementia. So there is a lot that they can do, and the key to behavioral issues is engaging them. So what I always tell patients when they come, or families when they come, is before we try and look at medication, let's observe. We need to really observe and see if there's a pattern to some of the behaviors. Is there a reason? Because usually there is a reason. So is it happening at a particular time of the day? Is it happening after a particular event? Because that would really help us understand. And then sometimes it might just mean changing the environment or changing the stimuli that's around or triggering these behaviors. It might just be turning on a light in the night. So it's very important to observe behaviors before we go into management, especially with medication, is what I truly believe, because a lot of the medications can interfere with cognitive performance, can make them extremely dull, and then they don't engage in everyday life. So the two main things with behavioral issues, I would say, is engage, engage, engage. And the earlier you start, the better it is. Get them into a routine, morning to night, have a timetable, get them to do things, and you will find that the body, the person gets used to this timetable, and they are able to reduce the behavioral issues. And then the other is observe and see if what might be triggering the behavioral issues. And I think post COVID, when we had to stop the activities at the center, is when we realized that these just having that routine of coming to the center a few days a week did make a difference, because a lot of our patients deteriorated, and we also see a lot of other patients who were not coming to the center but still did have a daily routine started to deteriorate. So it does make a big difference.
Thank you, Jwala. Just as we touched upon the behavioral issues, it's also, we do see that in certain patients with dementia, the first or the initial symptom may not be memory. It may be language per se. And it's only language, and the activities of daily living are not affected in the initial stages, and that's what we call primary progressive aphasias. So I just like Sonal to briefly introduce the primary progressive aphasias, because very often they are misdiagnosed as Alzheimer's.
Yes, so progressive variant of aphasias, they do not get easily picked up, because it is important that they start with the difficulty in speaking, getting correct words. They're still fluent. So there are different variants of progressive aphasias. A non-fluent variant where they are not getting correct words, they could be fumbling. And the fluent variant where you have a semantic dementia, we call it. And there's a third variant which is called logopenic variant. That's a mixed dementia of progressive aphasia. So language variant of progressive aphasias are FTDs, and you could have Alzheimer's atypical variant starting with progressive aphasia. We can have many different progressive aphasias which are starting with subcortical dementias like CBDs or PSP or FTD MNDs. So it's important that we understand how, as a speech language pathologist, as a neuropsychologist, as a cognitive neurologist, we are able to sensitize people to come to us, and we can help the person as a whole in terms of cognition, communication. And when we start, we help them identify them, diagnose them right. It should be really helpful.
And I think that is the area
So
where
may I
Rajwala
call-
was talking about
Yeah.
history taking. So history taking is very, very important here. The chronology of events is important. So I will
Yes.
direct my question to Dr. Sujit. Dr. Sujit, how frequently do you see progressive aphasias and language variant dementias in your clinical practice?
As Sonal has correctly said that to diagnose primary progressive aphasia is very difficult, and many times they are misdiagnosed. They are very rare. The incidence of, we can say, around 3 per 100,000. And if you ask me how many I see in my clinical practice, they are very few. Like I can see 1 in 3 or 4 months. So in a year, I may see maximum 3 or 4.
Okay.
As we see, the diagnosis is difficult because there are different variants. either they are non-fluent, they are difficult in speaking out, and they make grammatical errors. There may be slurring. So what we call it as a non-fluent aphasia. They may be fluent, but they are not. They have significant word finding difficulty. And for anything, they will use that this word, this thing, that thing. What we call it as a semantic dementia. So slowly, they have predominantly difficulty in the word finding, and they may stop speaking at the end as the disease progresses.
Later stage.
And then when it comes to logopenic, it is like mixed population, and they have predominantly difficulty in naming, and then there are mixed grammatic errors also. So they are usually associated. We have to look for other clinical features like whether they are developing Parkinsonism, especially progressive supranuclear palsy, or they have other behavioral issues like whether they are developing frontotemporal dementia, or sometimes they may slowly they worsen. And as Sonal has already said, sometimes Alzheimer's also directly sometimes present as a primary progressive aphasia.
Thank you. Is Nehal there with me? Nehal, I would like to know how many or how frequently you see PPAs in your clinic.
Good evening, ma'am. First of all, thank you for, am I audible?
Yes, you are.
Yeah, first of all, thank you for inviting me to this platform, Isha and IFNR. It is a great pleasure to talk on such an upcoming topic on dementia. So I think in my clinical practice, mainly because of lack of awareness what SLP brings in terms of the role and the expertise with which we can help, we haven't seen so many progressive aphasia here, especially in India. As opposed to when I was working in States, definitely it was much more that you were getting to see these kind of cases. However, post advocacy and my training in Lee Silverman voice therapy, we are seeing many more referrals for PSP, so progressive supranuclear palsy or Parkinson's. We are seeing more referrals for that rather than primary progressive aphasia. And even in this, what we see, the trend is generally that they are referred more for swallowing difficulties and speech impairments than identifying early cognitive impairments or dementia. So again, to stress more in terms of the role that SLP plays, there is again lack of awareness of what we can bring into, and hence in our practice, we see less referrals in that sense.
Okay, thank you, Nehal. Next question, Sonal. Is Dr. Rajinder still with us, sir? Hello, is Dr. Rajinder still with us? I think he wanted to leave by 6, that is why.
I think, ma'am, I don't see him here.
Okay.
He
Okay,
is
sir.
there.
So
No,
can
no,
we
I'm here.
Okay.
I'm here.
Okay,
Okay, sir.
Okay,
Okay, sir. So the next question is, why is early identification important in dementia?
So this is very crucial because it's a long-term disease, and as I said earlier, it doesn't only affect the individual; it affects the families. So the early identification is important because sometimes we need to have modifications in the environment in the house. Sometimes we need to teach the caregivers. Sometimes you need to diagnose and then put them on either behavioral therapy or the medications. So one of the most important thing which we have not touched upon is the sundowning. So most of these patients would worsen as the evening goes or the evening starts, and these patients will start either behaving in an erratic way or abnormal behaviors, whether aggressiveness or anxiety or wandering. So sundowning is very important, and it gives an early clue that the patient is having decline in cognition and needs either assessment or evaluation by the physician or the neurologist or the psychiatrist. The other thing is many of these patients initially they start going to either psychiatrists for their behavioral problems, and in many countries in US and Australia, there are geriatric psychiatrists who look after these patients. So from there, they go to neurologists or physicians, and they keep on wandering from one place to another place. So if we identify earlier, their multidisciplinary team can take care of these patients, whether the memory problem is there predominantly or predominantly behavior problem is there. So early recognition and treatment goes in a long way for long-term management of these patients, and these patients should be identified earlier, assessed earlier for their cognitive decline, the domains which are more affected than the others, a proper neuropsychological evaluation, which can take 3 to 4 hours, and then further management according to the deficits.
Thank you, sir. Dr. Krishnamurthy, would you like to add something?
I think two things that I always keep in mind. One is early diagnosis helps the person affairs in order and make plans. Focus on very much in India is advanced care directives. All of us, for example, would like to have a say on whether we would like to be intubated and ventilated in a particular medical emergency, for example. And it's even more important for the person with dementia because a few years down the line, they may not be in any position to participate in that decision. At a more pragmatic level also, setting one's own affairs in order is very important. So early diagnosis helps the person. It helps the family, because one of the things that we have in India is the parents in India, children abroad, pica syndrome, where, very often elders are here, the children are all settled elsewhere, and therefore for any care planning and care organization, early diagnosis helps, because then the right resources can be put in place. So I think that is very important. Third, we talked about behavioral and psychological symptoms, and we know that drugs, for example, actually increase mortality and morbidity when used, psychotropic drugs, when you use them for BPS. And really, non-pharmacological care is the cornerstone of care for many of these patients. And to organize and deliver non-pharmacological care, this care planning is important. There is a huge burden on caregivers, and therefore, again, early diagnosis helps people decide and plan how they're going to look after this elder with a condition that is progressive and is going to get worse and worse and worse. So for many, many reasons, I think we must focus on early diagnosis.
Thank you, sir. Nehal?
So as sir rightly said, on a similar line and length, I think what happens here is that everyone knows that dementia is a progressive condition. So the impact that it brings on the quality of life, and it affects not only the patient, but the family and the caregiver as in general, because if they progress to severe stage, we can see that it affects their swallowing ability to the length where they are not able to eat appropriately, they lose weight. Even other difficulties, like some of them cannot communicate at all. So they find they can only say a few words. They forget their family members. So in general, the condition goes to a much severe and advanced stage. Whereas if we identify them early, there is so much as speech pathologists that we can work upon. And we can work on rehabilitation and exercises which will prevent the progression, which will halt the disease to, escalate to this extent. So if we nip it in the bud and we identify the areas which they're struggling with, we can definitely prevent the progression and improve their quality of life and functionality and independence. So I think even emotional wise, they will not be so agitated, so withdrawn, and even socially they will be a little bit more connected otherwise. So I think early intervention is very important.
Okay. Nehal, we know that dementia is progressive. So can you just briefly tell us, very briefly, what are the major cognitive communication characteristics you see in the different stages of dementia?
Sure. So as we know that, first of all, dementia is associated with many other disorders. It's a condition by itself. So depending on what disorder, as in if it's associated with Alzheimer's, or it's frontotemporal dementia, or it's Lewy body or vascular, it will have its own different symptomology, whereas a few features will be highlighted more than the others. But however, what I'm going to talk about is we're going to talk about different stages of mild, moderate, and severe. So in that, let's try to understand dementia as a continuum. So in the generally as speech pathologist, we will assess the patient in 4 main areas. So the areas would be cognitive and language impairment, obviously behavior and personality changes that will have impact on their pragmatics or social skills. And last but not the least, very, very important, is dysphagia or their swallowing ability. So in the early stage, generally we will see is there is mild general confusion, or what we call is language of confusion, which will be different from patients with aphasia, as in it will be marked with more of cognitive and memory impairments. There will be little jargon. It will not be, the discourse won't be very cohesive. To give more examples, these patients will have more difficulties in problem solving or reasoning skills. So in that sense, if you ask the patient to make a grocery list and plan these items out, or if you give them a problem to solve, that if the car is broken, give us 5 steps how you would resolve that. These are the situations which these patients may struggle with depending on the severity, how involved they are. Sometimes just tasks like map reading and talking about it also can be difficult. There will be memory lapses. So in the early stage, it will be just like they will forget few items or names. Their working and episodic memory will be affected. But primarily, we see the hallmark feature is the executive skills are affected, planning, finances, and otherwise. Personality-wise, there'll be mild change and irritation, but most of these patients are able to do their ADL independently. So at this stage, mainly as speech therapists, we are seeing as, are they able to take the information, process it, and use it effectively for their functional communication? When we lead to moderate dementia, there, I think the one feature that changes mainly is they need help or assistance with their daily activities, activities of daily living. So they're even following sequential steps. If they have to do one task, are they able to follow the steps or not, is what something they'll struggle with. And as speech therapy, we help in planning with picture cards or with other assistive devices in explaining them that what will be the step number 1 or step number 2. And in general, at this stage, we will see increase in all particular difficulties. So there'll be increased in general language confusion, there'll be poor judgment, topic maintenance gets very difficult, word retrieval gets. But at this stage, as speech therapist, mainly we'll be focusing on is working direct intervention, working on certain deficits, and even working on few exercises or strategies which will prevent the progression. So maybe in swallowing, we can start assessing if there are minor difficulties here and there and work on compensation and rehabilitation. The last stage, which as the name suggests, it's severe stage. So all the difficulties are going to escalate to a great extent. You'll see most of these patients, as I said earlier, are not able to communicate effectively in sentences. They would be talking maybe only in words. And we have to help them with augmentative and alternative communication. Dysphagia, again, is one of the features that is highlighted here. They will face difficulties in eating. Sometimes because of forgetfulness, what happens is even if the food is in their mouth, they would forget to chew, and hence one of the strategy we will recommend is sometimes the bite size can be a little bigger than smaller if the pharyngeal swallow is intact. So, and here, obviously the patients on a severe spectrum may even forget their family and caregivers, and social participation becomes very difficult. So pragmatics also gets affected, and they may be able to work one-on-one, but not too much in groups or too much of processing of multiple instructions. So I think that summarizes what speech and cognitive characteristics we'll see at different stages. And I think as speech therapists, we must remember that all these individuals with dementia, they have their own experiences, they have their own stories. So we as professionals should ensure that we are able to help them keep connected with the community and their loved ones for as long as they can and foster their quality of life.
Thank you, Nehal. Sonal, we will come back to the next question later. Can you just we'll move on to advocacy and come back based on time. Next. Okay, I'll address this question to Ms. Bala. What do you feel is the general awareness of dementia among the public in India? Can you just briefly tell us?
Thank you, Nama. And I hope I'm audible to all?
Yes, you are.
Yeah. First of all, I would like to thank Isha for, inviting me to, contribute and, share my views. As far as awareness in India, I think I will sum up all the points that were, envisaged and, discussed by the panelists today, right from, what Dr. Krishnamurthy has told, about lack of awareness is the, underlying cause for late diagnosis. Therefore, the kind of interventions that we want to bring them and, resolve the caregiver's burden or stress is highly impacted, right? As a former carer, a lot of discussion has happened about frontotemporal dementia, and I would like to contribute my own experience, my personal experience with how that diagnosis came in very late for my father, who suffered from frontotemporal dementia way back in late 90s. And the kind of, trials and tribunals that we had to go through, running from pillar to post to find out what exactly was happening with him, whether it is the speech therapy, or, you're talking about how he would understand or, recognize a simple animal, which is in our vicinity, we call a cat in Telugu, pilli, and a tiger, puli, right? So my dad would always refer to a cat saying that puli veltondi. And sometimes, we thought he was joking, he just is trying to, pull a quick one with us. And then we never thought it was dementia, right? It started from there, and it, followed with him, having accidental falls, him being very anxious, him being very loud, him having, disturbances, like the sundowning syndrome. He would not sleep throughout the night, and we would literally had to hold his hands, at the night time, so that he will not get up and say that, it's time for me to go to the temple, right? And wandering was a big issue. And so these are all, symptoms that we have seen practically and in front of us happening. And then when we went to a general physician, because we never knew that, a neurologist was supposed to diagnose this problem. And I did my sister, who was in the US back then, she did a lot of reading, and, she said, guys, you're not supposed to be going to a general physician, because it was early diagnosis for my father. And therefore, general awareness, whether it was in late 90s that, I encountered with my father's experience, to today, I still have educated families coming to me, or calling me up, because they get access to our contact numbers from our website, calling us up and asking, my mother is not behaving properly, or she's forgetting things, or she's crying continuously, or she's talking to someone all through the night. These are few things that they keep talking to us. But then do you think they don't even conclude that it is dementia, or they don't even worry about the fact that there is something wrong and I need to consult someone at the earliest, leave alone reading some material or reaching out to a neurologist or a neuropsychiatrist, or at least go for a basic assessment to a healthcare professional. So lack of awareness in India, with the kind of population that we are looking at, close to 53 lakhs of people over the age of 60 having dementia in India. I feel that we have a long way to go from where we started to where we are today.
Okay, next question, Sonal. Next question. Bala, I just have one more question to ask you. What are the steps taken by various organizations like the ARTSI to resolve issues that are there with what caregivers face and patients face?
Yeah, I think like Nehal and the other teammates have told Jwala and the doctors. One thing that we advocate very strongly is to identify the problem early on and bring it to the table. So which means early diagnosis is something that we focus on, and we emphasize that by doing public awareness sessions, building dementia-friendly communities. Say, for example, like Dr. Krishnamurthy said, I need a team which can go to their doorstep and help the families out. So this is what I do as a professional, because I have realized the fact
sorry to interrupt. Do you have groups for carers too?
Yes, yeah. In fact, this particular session is being viewed by the Zeba Bashiruddin, Center for Healthy Aging, which is a WhatsApp group, which is having primarily all the caregivers, because we discuss about various aspects of the care, whether it is the sundowning syndrome, or it is incontinence, or it is swallowing issues, or chewing issues, or wandering issues. Each of the topic we take it up and ask these questions in the forums, whether it is a WhatsApp group or we pick up the phone and we discuss about it. In fact, we also, when I do home visits to the families, I tell them about the risk that they have with their current home environment also, whether there's a fall that can be prevented, or because we're talking about dementias which could be associated with Parkinsonism or a Lewy body. There'll be balancing issues, and also the medication. So like one of the panelists said, you take medicine and the effect of the medication to drain out is going to take some time. And are we aware of what could be the precursors? Is the family aware of it? The risks associated with the disease progression, and also the medication that is being administered.
Bala, I'm just going to go a little fast because we are running short of time. I have one more question. That is, what concerns of patients with dementia have been addressed in our national policies?
See, I think Dementia India strategy is, we have adapted to the global strategy principles, which are based on the 7 broader points. One is, to make it a public health priority. Second is, to create dementia-friendly communities by, spreading awareness and educating the families and, general public, and also focus on risk reduction. So how do we reduce the risk, especially with the potential of, vascular dementias being predominant in this part of the continent, and early diagnosis, treatment and support, and care for the persons with dementia. And support for the family members is another major thing that is focused on, in the strategy report. And also research and innovation, because we need to identify what type of dementia it is and what kind of steps or care we need to provide to the person and the family. And also the information system that is available for dementia diagnosis and management.
Okay, Krishnamurthy sir,
7 points on which
thank you. Thank you, Bala. Krishnamurthy sir, would you like to add anything on the last question that I just asked on the national policy?
I think national policy, Dr. Dameja is probably far more updated than I am.
Okay, sir, are you with us? Are you with us,
yes,
sir?
yes,
So could you just please address it?
Yes, the government of India has this division of non-communicable disease, which they deals with cancer, dementia, strokes, and cardiovascular diseases. So there's a lot of talk going on to implement policies, especially catering to dementing illnesses, and there are special budgetary provisions for that, and the government is cognizant of that. And I think because of this COVID, these priorities have changed now, but they will come back to the NCD division, and that policy would look after or the main needs of the patients with dementia and their families.
Thank you, sir. Now, now I would just like to ask Ruben. Actually, Nehal told us about the stages. So in the final stage, we know that they may require alternative augmentative communication. Can you briefly just tell us in just 2 sentences? I can give you only short time.
So basically, in the recent technological revolution, AAC for dementia has become a very interesting topic. So basically, we have got a lot of apps. So this is what I want to tell the caregivers and the public, that a lot of apps like Luminosity, Gray Matter, and MindMate. So these, they can download it in the phone and they can use it with the clients with dementia. So some of them will not be able to come to the centers and all. So with this, you can use it. Second thing, what I want to say is that there is something called as memory books. So memory books is something which I use with my client only. So it is basically on the basis of reminiscence therapy. That is, you bring back their old memory. So Banker was a patient of mine who had suffered from dementia. So I took him to his whole bank, video recorded that scenario, his friends, and whatever he does in the process. And later it was made into PPT and showed. So after that, it became more easy for him to remember the words he wants to speak. And it was also helping him to improve the quality of life. So that is another thing which I want to tell. And actually, we cannot say one AAC technique or tool for all clients. So each client is different. Indeed. And based on the cultural things and based on the socioeconomic status, we have to choose based on the clients and give a AAC strategy. This is what I want to say.
Thank you, Ruben. Sonal, can you just go back to the tips for caregivers? This is a question that most of the caregivers address. I mean, they face and they ask us is, how do we address or how do we communicate to patients with dementia? So briefly, can you just touch upon that? Sonal?
Yes, for effective communication to be built with a person with dementia and caregiver, one needs to have a patience, respect, empathy while communicating with them that they are not mentally challenged, they are not mentally ill, they have forgotten a lot of aspects in the daily living. However, they are the same for you. So that is important. We need to supplement the spoken language with tactile and visual cues. We need to check that do they have adequate amplification, if hearing aids are required, if they have a hard of hearing, visual acuity has to be corrected. We need to repeat the sentence, speak slowly, rephrase it, stick to one preferred language, don't switch to English, Hindi, Telugu, Marathi. We are multilingual, so we need to understand that they process slowly after the dementia, and give eye contact, talk to them with simple signs, make picture communication boards, don't change environment so easily that they forget where are they. We need to validate Sonal. Giving eye contact. That could be some helpful communication tips.
Sonal, can you move to the last question, please?
I'm just trying that. Yes.
Okay, so
the last question of the session, and we
the last question that which I'm going to ask is, what is your hope for the future for persons with dementia, and what more can we do? Dr. Damija?
I think we need to touch two important things which we have not so far discussed. The one is that it's a team management, it's a team effort to look after these patients involving physicians, neurologists, SLPs, memory specialists, occupational therapists, and every player has a role to play in this management. And the second thing which we have not discussed so far is neuropalliative care. So that is very important for these patients in their advanced stage of dementing illness, where they are not able to take decisions, and the palliation about it's just not the the ventilatory support or the other terminal illness. It is making the life comfortable right from the initial stage to the last stage. So neuropalliative science has a role to play in the patients with dementia, and it is being recognized more and more in our setup also. It's well established science in developed countries, but we have now started in India also, and Kerala has taken a lead in this, and they have set up a Kerala model for neuropalliative care. It's basically started with cancer, but now it's involving dementia and other degenerative conditions in the elderly population, and their whole aim is to make the life comfortable. It's just not the terminal stage, but symptoms control and improving the quality of life. There is a hope with the more awareness of this illness, whether it is by the diagnostic evolution in terms of biomarkers, early clinical diagnosis, and holistic management of these patients with the team.
Thank you, sir. Krishnamurthy sir, can you just add a brief sentence, because we are running short of time?
Absolutely. I think one of the things to also keep in mind is culturally validated care paradigms that are acceptable and embraced by our people. And there's excellent preventive health that we can bring in through integration which is available in Ayurveda and yoga. Jwala talked about using yoga. We use a lot of Ayurveda, naturopathy, and yoga as part of dementia care and MCI prevention. So I think we should be talking a common language, which is teamwork. And the team is not just a modern medicine multidisciplinary team, but an integrated team, because I think then we can access many more people across the world.
Thank you, sir. Sonal, last slide, please. I think I will take this opportunity to. Yeah, I think I will just take the opportunity to thank our very esteemed panel for giving us such an enriching experience. And at the outset, I would like to thank Isha for having allowed me and Sonal to moderate the session on dementia. So I think we all need to work together to make the lives of all these individuals who are suffering from dementia and other neuro-related cognitive disorders. We need to work together to make their lives meaningful and to help them live in a dignified manner. Thank you so much. I'm not sure if we have any time left for questions.
I think, ma'am, we have 2 minutes to take a quick question.
Yeah, you can take one question or two questions. Should be good.
Okay. So may I ask Dr. Jagtap, is he there? Dr. Sujit?
Yes, Sonal, I'm there.
Yeah. So at what age MCI is diagnosed and the dementia can be seen is one question. And how do you go about the right treatment in early MCI is the question asked.
Usually, MCI is the first step of the diagnosis towards the dementia. And the age what we usually see now in the 6th decade of life, usually after their retirement. And then sometimes we can see early MCI also at 7th decade also. But there is not such an age limit, because sometimes those who have family history, in them, again, it can be have earlier age of onset. If father or mother has at age of 70, they might get at 65 or 60. And the subcortical dementias usually present early, like in the 5th decade of life. So again, with the dementia with Parkinsonism, they present early. And that is important. What is your second question?
The approach of management with MCIs.
Yeah, here the management approach towards the management is again whether we have to subtype, whether it is a Alzheimer's dementia is like Alzheimer's type, or whether it is some reversible cause is there, or whether it is like subcortical or dementia with Parkinson's disease. Each has different, because we have very few drugs for the management of the dementia, but we require holistic approach, and it should be the teamwork and involving caregivers as well as the speech language pathologist, then neuropsychologist and neurologist, and also psychiatrist, all important parts in the approach towards the management of MCI and dementia.
ESK, could you please add quickly and conclude?
I think I will once again emphasize the importance of teamwork. And I think it's very important that we set up a system whereby from assessment to continued care, the whole team is working with the individual. Any one person, including the speech and language consultant, can be the lead for an individual patient, but everyone else should be able to contribute as and when required. And I think that kind of seamless teamwork would be very, very nice, because I think that brings the patient care to a very good, optimal level. So that's what I would wish to see.
Thank you so much, sir. Thank you so much, all panelists. Thank you all. I would like to thank organizers for this opportunity and the great session. Hope we all have a good enlightening message in the cognitive communication, rehabilitation, and dementia. Thank you so much, all.
Thank you,
Thank you.
Sonal.
Thank you.
Thank you, Annama madam.
Thank
This
you.
was,
Thank you very much.
Thank you,
and
ma'am.
this was very enlightening. We would say that you said for giving you this opportunity, but we said that there couldn't have been any better moderator for this session than you two both.
Thank
You
you,
are
Dinesh.
an advocates for this cause, and thanks to the entire esteemed panelists. Over to Dr. Sunil Ravi, sir, for closing remark, and then we.
Yeah, good evening once again. And the session was a very fruitful one, starting from dementia to Alzheimer's and to other diseases that are causing the cognitive impairments in elderly population. So the take-home message for everyone: if any person is having a memory impairment or impairments in terms of attention or thinking or listening abilities and so on, please consult the medical professionals. It can be a neurologist, it can be a neuropsychiatrist, a neuropsychologist, or a speech language pathologist, and get yourself assessed, tested, and then diagnosed for if you have any problem, and then take adequate treatment initially so that you can have better life even after the age of 65, 70 years, and so on. Thank you once again to all the moderators and the panel members for taking time and for sharing your knowledge to all the public. Thank you once again from EAC of Indian Speech Language and Hearing Association. Thank you all.
Thank you, sir.
Thank you.
Thank you, Sunil.
Thank you,
So
Sunil.
now we would
Thank you.
move to the next session. I'm sorry because this is like one after another. So once again, a big thanks to the existing panel, and we move towards the next.